Hi, welcome to Detours Understanding Acquired Brain Injury. And this is what doctors might prescribe. In this little few part series, I'm going to be talking about medications that a physician or another advanced practice provider might prescribe for your loved one if they land in a hospital or rehab, or things they might prescribe, medications they might prescribe if they, at home. Now the purposes is people have asked me, what are the different kinds of medications, and so I felt I'd at least go over some of the basics. I'm not going to get into depth about doses or any of that kind of thing, but I do want to at least cover some details, just so people understand what they might be taking or what the purpose of some of these medications is. So let's just get into it. Okay. Now, first of all, I do want to discuss a few basic concepts for prescribing for a person with acquired brain injury, because there are some unique things we need to understand. Because prescribing for patients with acquired brain injury requires understanding how brain injury alters how the body and the brain react to medications, because brain injury has a profound effect on the pharmacology and the pharmacokinetics, which is a term that describes how the brain will break down, absorb, and excrete medication. And so it's important to address this. One thing to keep in mind also is that much of this is speculative, and we're still learning about how the body interacts with medication. And we don't exactly know how many medications work. A lot of these things have been learned through trial and error. If you have questions, please speak to your pharmacist, please speak to your doctor. Remember, this is an educational video. This is not meant to substitute for your physician under any circumstances, because it's a matter of safety, and because, it's like each person is different and how their bodies work is different. And so we just want to stress that this video is meant for education, and that really, if you have a problem, if you think you're having a reaction, anything like that, any kind of concerns, please, if it's an emergency, call 911. And if you've got questions or problems, please talk to your doctor, go to the emergency department. Okay? So, first of all, everybody's brain is different, and everybody's brain injury is different. And so what works for some celebrity or whatever, and they're talking about any of their acquired brain injuries or whatever, what worked for your cousin, your best friend, whatever, may not work for you, because genetics, epigenetics, all those kind of factors, and just how your body works, different. So just because cousin so-and-so said, oh, you need this. Nope. You need to stick with what was prescribed and given to you by your physician. The only way you know is if it isn't working after a while, or if there are side effects, things like that. And it's important to understand, what one person's side effects are another person's effects. Because with all forms of medication, what you might consider a side effect for one medication is actually an effect for another. So that's just a label of effects we don't want. So I just want to go over that. But what one medication does may not be useful under these circumstances, but it may be useful for in medications for another. So it's always important to keep that in mind. Also, so all right. Second, medicine is a field where there, tends to be conservative, because we need clinical trials, repeat clinical trials, demonstrate the safety and efficacy of medications. So this is why it tends to move slowly. Also, because there are many things we still don't understand. So I just wanted to touch on this. This is why things tend to move slowly, because we depend on evidence. You'll hear the phrase evidence-based medicine. This is why. So we're still learning a lot. Okay. Body is a complicated thing. Brain, really complicated. Brain injury alters the way that drugs are stored, broken down in the body, and processed, in the brain. Loss of neurons and support cells, glial cells, immune cells, all that kind of stuff in your brain affect how, after a brain injury, affect how medications are absorbed and used. And it may also have an effect throughout the rest of your body. If there's damage to the pituitary, if there's damage to other parts of the body, this has an effect also. So it's important to keep in mind, especially for those of you who are taking other medications, that a brain injury may change how long-time medications that you've used or medications that are intended for other purposes interact and affect the body. Okay? Breakdown of the blood-brain barrier or neurosurgery may cause inflammation. Inflammation may release the immunoglobulins. It may release macrophages, microglial cells, things like that, which may speed up or slow down absorption of medications requiring higher doses, lower doses, may affect how drugs interact with each other. Brain injury causes epigenetic effects, changes the way that enzymes work, may release proteins from the body that aren't usually present in the brain. Again, complicating these matters. So it is important, again, to understand that what somebody tells you, how something should work or how it does or does not work, may be a factor. And so it is important to keep this in mind. Again, when dealing with what you look up, what you hear from people, what you know, this plays a role. And why medicine is such a complicated field, and brain injury medicine is really a brand new study. So please, try and ask questions, try and understand, but understand that each person is unique and different. There are a lot of things we all share in common, but it will require tweaking and adjusting doses and, as they go along. And many of these principles, then there are specific principles that a brain injury medicine physician needs to go by then when they're working with a family, a loved one. And it requires understanding, and it requires kind of patience, which is really hard because most of us are used to thinking, like a broken arm or whatever, after 6 weeks, you'll be back. With brain injury, there's a lot of unpredictability, and this adds to complications. There are a lot of unknown mechanisms for many medications, as I said before, and so trial and error, or based on the shape of the molecule, drives how we explain or understand how things work. This is where AI plays a role in computers and modeling what fits into a receptor, and we know that if you hit this receptor, it increases or decreases the chances of this neuron firing or releasing certain hormones. And so that's how many things are developed. Also remember that a lot of medications are used what's called off-label. Now, off-label means the FDA has approved medications for certain purposes. Like maybe this is a heart medication, or maybe it's an antiviral. But through trial and error, through research studies, we found that, one of those side effects is actually a good thing, and we can use it for something else. And so we're using this medication off-label because a physician has, or a nurse practitioner, PA, or whoever, they have a right to prescribe, and they have a right to prescribe medications for all different kinds of purposes. So they read journals. I mean, I read a ton of different journals. And so it's like, and they'll tell you, there are these 3 studies where they found that using this medication helps, like, for example, reduce brain swelling. Even though that's not the purpose of medication, we found that it causes blood vessels to, say, dilate and absorb fluids. Well, that's great. These studies then it'll explain, it says like maybe they've recruited so many hundred people, and they found that, as an effect when they were using it for something else, that there was a change in blood pressure due to absorbing fluids. And it's like, some doctor out there was like, hey, and went and asked his or her review board, can I use this medication to try to see if it works on brain edema at, different doses? And they got a bunch of people to try it out, and they found that, it works great for this. And now it's being recommended. And eventually you'll find that there's another recommendation for it. It's used to reduce brain edema over time by the FDA. But initially it gets an off-label use. And so you'll be wondering, why use, say, an antiviral? Well, because we found through research that it helps. One of its side effects, now it's being considered an effect, works this way. And so it's important to understand if we're being given something, a loved one's being given something, and you're like, wait a minute, I thought that was for this. Well, it's being used off-label because research has shown that it works also for this condition, and eventually it becomes an on-label use. Just so you're aware of that kind of thing. Now, here are some principles that are important for a brain injury medicine physician, and they'll follow these, just so you understand why things are working the way they do. First, if you're prescribing for a survivor of an acquired brain injury, they'll tend to start low, go slow. So many times they will start with a kid's dose because with brain injury, you may have lost neurons and can't handle an adult dose. So start low and they'll go slow. So they'll increase the dose slowly, but they need to remember to go. So even if they start at a kid's dose or lower, they will still creep up until they hit an effective level where they get what they want. Another principle to remember that's equally important is err on the side of cognition. So if there are multiple medications that interact with each other, and one of them might affect thinking or processing, and the other one might improve smoothness of movement, it's probably better to select the one that doesn't interfere with thinking, because a person with brain injury already struggles enough with thought. So it is better to avoid the medications that mess with thinking, even if it means the person may have movement disorders or things like that. So better to stick with those meds that don't alter your cognition. Some medications like antispasmodics, antispasmic medications, antispasticity types do tend to make you sleepy, interfere with your thinking, stuff like that. Too much of the psychiatric meds, they can interfere with thinking. So it's important to strike a nice balance. Also, another principle is increase until you hit the minimum effective dose. Now, this is true for medicine in general. You should only administer until you finally hit the dose. But people with brain injury tend to have a lower effective dose. And so rather than sticking with a textbook, brain injury medicine docs tend to aim a little lower, and so a lower dose, and you're like, wait a minute, that's a kid's dose. Yeah, it's a kid's dose because loss of neurons means that maybe a lower dose may be all that it takes to be effective. Also, if there's a non-pharmaceutical way to treat something, try that first. Combine low doses of pharmaceutical with the non-pharmaceutical way, like behavioral techniques, cognitive behavioral techniques. And finally, there are no pharmacological treatments for traumatic brain injury or acquired brain injury directly. There are no cures. The best you can do is treat symptoms. Now, this is true for a lot of chronic illnesses, but it is always something to keep in mind. Okay, so now shifting a little bit here, throughout the treatment of the illness of acquired brain injury, regardless of what it is, you generally have a couple different goals, and depending on what setting you're in. Now, mainly, as I said, for this episode, we're going to be looking at the pre-hospital and hospital and rehabilitation hospital. So mostly the medical environment. We won't be talking about meds at home. We'll be talking about medication given, under the direct care of like physicians, paramedics, nurses, that kind of thing. And so a lot of the medications we talk about are intravenously administered. So they're given directly into the vein or through a central line, which is placed, directly in a major artery. It's, and so these medications, the reason we're talking about this, another reason is you may see something like on an IV bag and you're like, what the heck is that? it'll be one of these things. Okay. And so let's go through, first of all, what are the specific goals and aims for a doctor, NP, whatever, to treat? In the pre-hospital environment, in the emergency room, trauma bay, or OR, these are the goals. Okay. So first, they want to prevent cardiac and respiratory problems. Okay, first and foremost, the patient has to be alive. So the medications they get will be one of these things. Either prevent cardiac and respiratory problems, to maintain vital signs at a stable level. You don't want that blood pressure down. You don't want the heart rate too low. You want to keep them as normal as possible. Reduce hemorrhage. We know that, shock, bleeding, those things are bad. So, avoid that. You want to reduce intracranial pressure. So we've talked about brain swelling in our video about traumatic brain injuries and other kinds of injuries where you talk about vasogenic shock and cytotoxic shock. Bad. So we want to try to avoid that too. We want to avoid agitation as patients begin to wake up, or if they're kind of half awake and asleep, and we want to keep them comfortable. So different kinds that you'll see in EMS. Fluids and volume expanders, as well as if it's like a flight program or major city program, you're dealing with IVs, which are normal saline. So it's kind of blended and mixed to chemically match your blood. However, and this is important to keep in mind, it doesn't replace the red blood cells. So you don't have the capacity to carry oxygen. So if you're dealing with a patient who's in shock, a normal saline will not replace that capacity, nor will it carry really any nutrients. That's something separate. But at least it will keep your blood pressure from crashing. It'll keep you stable long enough to get you to a hospital. Now, some programs, helicopters and, acute care do carry whole blood, which is of type O, and those whole blood is complete blood, right from, the patient is checked it right from a donor, right to the patient. This can stand in. But if you've got somebody who's seriously bleeding in a motor vehicle accident or something serious, a gunshot wound or to the head or, whatever, a penetrating traumatic brain injury, they need to get to surgery to keep them from continuing to lose. But at least whole blood will keep them together. Now, you can give them other blood products, packed red cells, plasma, things like that, where they break apart whole blood into its constituent units so they can keep them for longer. But the best is whole blood. And this is one of those things they use. Or most pre-hospital programs, EMS, do give normal saline solution. They also may give lactate ringers. Haven't seen that as much often lately, but, that also is, for maintaining volume. There have been experiments with artificial blood, but for some reason we really haven't had much luck with getting its capacity to carry oxygen and things like that. Work is ongoing, as always. Second, advanced cardiac life support drugs. These are used if somebody has cardiac arrest, if their heart rate, if the breathing's low, rate is low, the respiratory rate's low, blood pressure, any of these kind of things, vasodilation, they're going into shock. These medications are used to stabilize a patient. And again, they're used to keep somebody alive. They're keep them from either to help resuscitate them if they're salvageable, or to keep things from getting worse, to keep them stable, vital signs stable, breathing, heart stable, to prevent an aberrant rhythm, problems with our heart. That's what this is all about. These are the life-saving kind of basic, and you'll find them on advanced life support ambulances. We talked and did the interview for the ambulance squad, and you'll find them for air care, and you'll also find them, of course, in the emergency department. But an EMS crew carries these. The advanced life support EMS crews from your local community has these medications just like the ambulance does, or just like your hospital does. So, it's like they are more than just a ride to the hospital. They can treat you in the same way you'd get treated in the ED. Obviously, they carry oxygen, which is necessary for, well, obvious reasons. Many EMS units carry pain relievers, not just over-the-counter stuff, but they do carry like fentanyl, and they carry like morphine and other things. The problem is with people with brain injury, you've really got to be careful that you don't make their condition worse, depending on what medications you're giving them. And those with neurotrauma, this is where the expertise of the anesthesiologist or nurse anesthetist is helpful. So you have to be really careful. And so really sticking more with helicopter EMS, they may carry propofol, which is a drug that also reduces intracranial pressure and has its advantages. But that's something mainly carried, and administered by flight nurses or flight physicians and flight paramedics. And so generally ground crews don't carry that kind of thing, generally, unless they have a specialized transport unit. So anticonvulsants, they do carry things like midazolam, which is a benzodiazepine. We've talked about how that's not so good for you, but, that is something else that ground EMS may carry and may administer to a loved one. Phosphatoin, phenytoin, and Levictrum, anticonvulsants to prevent seizures, early onset seizures, gunshot wounds, severe traumatic brain injury, hypoxic ischemic encephalopathy. These kind of medications given by ground EMS crews, because seizures may worsen things substantially, and those kind of injuries are most common cause of early onset seizures. So you want to try to prevent post-traumatic seizures. Very important to use those kind of things. And finally, and in some air crews do carry some sedatives, as reduction of intracranial pressure. So there are a couple options for that. The two medications for that are the common choices now, which are mannitol. And I remember then when that was being introduced back when I was running EMS, and this was a big contentious thing, now it's common, or 3% hypertonic saline, which is a special formulation of the saline solution, IV. Remember how I talked about these side effects that are actually beneficial? Well, this one pulls water out of the cell and causes reduction of swelling. Water follows salt. So high salt concentration will pull fluid out, and it will pull the fluid out of the swollen neurons, and so it'll reduce intracranial pressure. Not every ambulance would carry this. Many helicopters do, and you'll find it in the emergency department, but you may not find it in your local crew, or they may not have orders to give it. They may have to call the doctor on the radio or by phone and say, hey, can I give this? The mannitol, same thing. And that's one thing that's important to keep in mind. A paramedic has to get, at least in the United States, there are different rules in different countries. They're more independent in like the UK, Canada, Australia. The paramedic here has to call a physician on call, command physician in the emergency department to get permission to give some of these things. Others follow protocol sets of orders that are signed off by a group of docs and follow those, because a paramedic's not a physician, so they have to have orders to do their treatment. Miscellaneous and experimental, taxonomic acid to prevent hemorrhaging. It encourages clot formation and neuroprotective agents. Experimental medications to prevent further secondary brain damage. We've talked about how there's a secondary cascade, glutamate toxicity, and all these things. We've discussed this before, but the excessive release of certain neurotransmitters, excitatory neurotransmitters, can further worsen brain injury, and so the use of new medications to try and reduce this. there are a number of ground and air EMS programs that are experimenting with the use of these drugs in order to protect the brain. And so they may be participating in an experimental program, the TXA. We at first thought that this was, great. Now the research is questionable, and this is something that happens in EMS since it participates in a lot of research because they're much closer to the incident where the patient was first hurt. And so now we're at this point where it's like, the experimental results are equivocal, but we still see its use. Then there are other treatments that they'll receive when they hit the trauma bay. It's everything that we just talked about for the emergency department. The same fluid, blood products that guarantee no matter where they go, whether it's to a trauma center or a general hospital before being transferred, or if it's less serious, ACLS meds, anesthesia if they're going to receive neurosurgery, or pentobarbital. If there are ongoing problems with brain swelling, they'd get pentobarbital to help reduce the significance of the swelling. Pentobarbital is used to maintain a patient in what's called a medication-induced coma or drug-induced coma. That's the primary agent, although propofol is also used. Both of these help with refractory intracranial pressure. So that's what's being usually given to them to keep a patient asleep if they would wake up and be agitated. There are also, one of the things that they will avoid is benzodiazepine. So no Valium, they should be avoiding no Valium, midazolam, any of those in that family, because it works on the GABA receptors, the same ones that alcohol works on. So they generally try to avoid those. So it's more likely pentobarbital or it's propofol. That's a whole complicated thing because propofol also works on the GABA receptors, but there's other types of receptors that are, we don't have to get into all that. But it's like subtypes and things. No, we're not. Again, neuroprotective agents. Also, depending on whether they're going to go to the operating room or whether they're going to go to the ICU, if they place an ICP bolt and an extra and a ventricular drain, then there'll be other treatments when the patient gets to the neurotrauma ICU or post-surgical ICU. And the treatment then changes again a little bit because the goals change, because the patient will stay in the ICU and step-down units typically a little longer. So then you're trying to prevent clot, like clotting in the legs, arms, DVT prevention, deep vein thromboses. Those are dangerous because the patient can throw a clot into a place they don't want to. Still trying for seizure prevention. And if the patient didn't need neurosurgery, then you're still trying to keep their ICP, intracranial pressure, down, and maintenance of vital signs. You're also trying feeding them. If they're a long-term, if they're in a coma long-term, or they're going to go to an LTAC, long-term acute care, you may switch from nasogastric feeding, where you place a tube down, you through their nose down into their stomach, like this. Then your options change a little bit. And so, if you put a PEG tube in their abdomen or down into the jejunum in their bowel, like this, then you're changing your focus for feeding. So you've got nutritional concerns, endocrine concerns, so endocrine and medications you may need to give them insulin. Because it's a high caloric content, and maybe they're right on the line for diabetes. So you've got that to worry about when you're dealing with that short course of antibiotics. If they have a penetrating traumatic brain injury, you've got that to focus on. Typically, it's only a short course, even for penetrating, because the research for whether antibiotics make a big difference, if they're going to be on a ventilator for a while and they have a trach, that may require a longer period. Or if they're at risk for skin infections, which is something else. Then you're putting on skin cream and you're treating them that way too. So those are additional treatments as well as the other stuff that we have mentioned. So also, as they start to wake up, you need to think about medications to fight agitation. And there are a variety of those that are used. You may use beta blockers, which prevents kind of a feedback loop for emotional. And it also helps. This is one where multiple effects are useful, off-label. Beta blockers not only, but they also prevent neurostorming, which is basically a hyperactivity through the autonomic nervous system. It helps keep things down. It keeps blood pressure regulated too, but it also prevents agitation and aggressive behavior during that confusional states. You may have to rely on antipsychotics. Again, it's like those are used to help, and mood stabilizers to help keep things steady, although maybe not as early here in the ICU, but when they go to step down and start to show more awareness. Although that definitely you see more when they move out towards the acute care rehab. There you start to see more of the cognitive agents and more of the neuropsychiatric and neurocognitive medications. Because here it's more like supporting their basic life functions. They may need medications to help them, either diuretics to help them pee more, or antidiuretics to help them if they're having bladder problems. Again, this is where antibiotics may be necessary if they have a UTI or develop upper respiratory infections from iatrogenic or community-acquired respiratory problems. They may receive, for imaging, they may need contrast. And you'll have to treat in the ICU and the step-down units any kind of potential other problems that crop up. You may have to provide supplemental nutrition for things like calcium, magnesium, which also has effects on cerebral blood flow. So there are benefits with that one. Potassium, that has cardiac effects. So monitoring that, if they're having high or low potassium, high or low calcium, all of these things have systemic effects. You may also see administration of that. The ICU is a really intense situation, hence the intensive for ICU, but that's where they'll receive the most medications, IV, and it is mainly to maintain life functions. And a lot of these medications are, essentially, they are artificial organs. They take over a lot of the functions of the body using the machinery in the ICU, and they support the patients. They may have to do microfiltration. They may have to have them on, vent or other devices to supplement organ function, because when the brain's down. And I do want to eventually talk about the ICU separately, but a lot of medications there are for those kind of purposes. When you finally get to the rehab environment, there you're dealing a lot more with, and the patient is well enough, there you're dealing more with disorders of consciousness, medications, things to help wake up a patient. If they're not waking up and they end up elsewhere, there are medications to help increase arousal. Those I do want to talk about separately, but there are meds to help patients that are having disorders of awareness, hypoarousal. Again, anti-agitation medications, anticonvulsants, anti-seizure medications, usually a max of 7 days to prevent early onset seizures. Of course, patients can develop seizure disorder from their brain injury much later, but there's been no proven link between early onset seizures and brain injury-induced post-traumatic seizure disorder, which could pop up years later. So preventing seizures now is good, but it doesn't guarantee you won't get them later. So Obviously, opioid and non-opioid pain relievers, very important. Antispasmodics. These are important for like a patient who is very contracted or who has a lot of pain and they can't, in order to do physical therapy, occupational therapy, those kind of things. The antispasmodics. Cognitive agents to help memory function, processing speed, focus. Yes, they're out there. How well they work, I mean, it's like, again, antidiuretics, diuretics to help regain bladder function, things like that. And tube feeding, we still are doing that, especially in the high level and the high acuity rehabilitations. As far as that's concerned, skin creams to fight breakdown, especially with problems with mobility, things like that. If there are, antimicrobials, short trace of, short course of antibiotics as needed. And then when they're doing the outpatient kind of things, then it's like more ordinary medications, pain control, NSAIDs, Tylenol, ibuprofen, and they may be given a little bit, very low dose, of neuro. This is where you finally start to see more of the neurocognitive, neuroprotective agents, or I'm sorry, neurobehavioral stuff. Forgive me, not the neuroprotective. That's, like I said, a lot of research on that. Nutrient, you may get the NSHORs, they may give them the NSHORs. If they need any of the neuroendocrine kind of stuff, if they develop diabetes or some other thing, depending on their condition, obviously you have to learn how to use that. This is where you use the sleep agents because they're not receiving hefty doses of pain medicine or sedatives, okay? If they need the anticonvulsants, if they develop seizure disorder, and anything miscellaneous. But usually we're pretty light, and we've gotten away from the IV kind of stuff by this point, because now our goal really is to transition them to home at this point. All right. I hope I was able to cover quickly some of the basics and you were able to learn. And if you have any questions, please post them below. It's this topic is really a broad one, but each area is rather involved, and I do plan on focusing on each section and describing each group of meds specifically and dosing and things like that. But I just wanted to give you the 30,000-foot view of a very broad topic in order to answer some of those kind of questions. Please click like and subscribe. Don't forget the bell icon. Friends with Brain Injury is the parent company, and we do have a Facebook group that you can be involved with. We have 2 different times for our support group. And so please, we hope you participate with that and share if you found this helpful, please. And hope to see you around again. Bye.